Thank you, Mr. Chair and members. This is my disaggregated data bill to collect data in a disaggregated fashion in the health and education arena to provide important data that can be used to drive policy in a more informed, targeted way to solve problems.
Second.
We have a motion and a second.
Thank you. I have Lanrick John of the Asian Pacific Islander American Health Forum with me today.
Good evening, committee members. My name is Ian Rick John with the Asian and Pacific Islander American Health Forum. I'll keep my remarks brief this evening. For nearly 30 years, the Health Forum has been working with community organizations and policymakers to address health disparities and improve the health of Asian Americans, Native Hawaiians, and Pacific Islanders in California and across the country. And we know that the collection and reporting of disaggregated racial and ethnic data is essential to improving the health of communities. As you know, Asian Americans, Native Hawaiians, and Pacific Islanders are part of a very diverse community representing many different ethnicities and language groups. With the collection and reporting of state data on smaller Asian American and Pacific Islander groups, many of which are specifically mentioned in this bill, their potentially greater health needs and disparities are likely to be overlooked or underestimated. Income, education, English proficiency, and country of birth are all factors that influence the health of communities. With a better understanding of these demographic factors combined with health-related data from subgroups that AB 176 would make available, we can really begin to understand the Asian American and Native Hawaiian population in California and whether the health of Malaysians is different from the health of Chinese or whether the health of Tongans is different from the health of Samoans. In addition to data collection, making the data publicly available and accessible is equally important, so researchers can identify health disparities and policymakers can work with communities to implement targeted strategies to address health disparities. To close, I'd like to thank Chairman Bonta for his leadership on this issue, and I urge the committee to pass AB 176. Thank you.
Okay.
Kimberly Chen on behalf of the California Pan-Ethnic Health Network and the Alliance of Boys and Men of Color Health Work Group in very strong support.
Further witnesses in support.
Elizabeth Landsberg with the Western Center on Law and Poverty in support.
Beth Capel for Health Access in support.
Other witnesses in support. Seeing none. Witnesses in opposition. Seeing none. Questions or comments from the committee. Seeing none. Mr. Chairman, you may close.
Thank you for your consideration, members. I respectfully ask for your aye vote.
We have a motion and a second. I'd ask the clerk, it's due pass to appropriates. I'd ask the clerk to please call the roll.
Bonta?
Aye.
Bonta, aye. Mainshine?
Aye.
Mainshine, aye. Bonilla? Burke? Burke, aye. Chavez? Aye. Chavez, aye. Chu? Gomez? Aye. Gomez, aye. Gonzalez? Aye. Gonzalez, aye. Hernandez? Aye. Hernandez, aye. Lackey? Aye. Lackey, aye. Nazarian? Aye. Nazarian, aye. Patterson? Patterson, aye. Ridley Thomas? Rodriguez? Aye. Rodriguez, aye. Santiago? Aye. Santiago, aye. Steinnorth? Aye. Steinnorth, aye. Thurman? Aye. Thurman, aye. Waldron? Aye. Waldron, aye. Wood? Aye. Wood, aye.
16-0. Your motion passes, or your item passes. Next is your item, Mr. Chair, item 8, AB 533.
Yes, thank you, Mr. Chair and members. First, let me start out by stating that I'll be accepting the technical amendments offered by the committee. AB 533 does one simple thing. It takes patients out of billing conflicts between health plans and physicians when the patient follows the rules about receiving health care services. Many of us have experienced, heard of, or know someone who has experienced a surprise bill. These bills range from hundreds to up to tens of thousands of dollars and are pushing some consumers into bankruptcy. We have had many discussions with the stakeholders on this important issue, and everyone on all sides agrees with the fundamental concept of the bill, that patients should not be involved in these billing disputes. The current language in the bill does just that. AB 533 takes the patient out of the middle of the dispute and requires enrollees receiving services from out-of-network physicians at in-network facilities to pay only the in-network cost sharing, or in other words, the same cost that the enrollee would have paid to the physician for covered benefits if the physician was in-network. The follow-up issue related to this first issue, though it is not our original primary intent of the bill, is to determine what fair payment is between the health plan and the physician. This is a thorny issue that requires a thoughtful approach, as there are many options to consider. I've been working with the opposition on this bill and will continue to do so, looking at whether the bill should be amended to include an independent dispute resolution process, or IDRP, and an efficient, equitable process for determining reasonable rates for non-contracting physicians. I commit to continue to work with the opposition on this important second piece as we continue through the legislative process. With me today are Tam Ma with Health Access California and Betsy Imholtz from the Consumers Union.
Move the bill.
We have a motion and a second. Witnesses in support.
Good evening, Mr. Chair and members. My name is Tam Ma, and I'm with Health Access California, and we are proud sponsors of AB 533. Most consumers with private health insurance expect not to be responsible for costs beyond the premium and copay, deductibles, or coinsurance. Even the most careful consumers who go to in-network hospitals and other facilities, however, can end up being treated by an out-of-network provider and then receive a surprise bill for the difference between the provider's charge and what the health plan is willing to pay. These out-of-network providers include the anesthesiologist you barely meet as you're lying on a gurney, the pathologist whose name you never know who reads the slides, and the radiologist you never see who reads the image. Bills for out-of-network providers do not count toward the annual out-of-pocket maximum imposed by state and federal law, exposing consumers to more than $6,600 a year in medical bills. California law already protects consumers with Knox-Keene license coverage from balance billing for emergency care. We need to extend this critical protection to non-emergency care and to consumers who have coverage regulated by the Department of Insurance. AB 533 simply holds unwitting consumers harmless when they get care at an in-network facility by letting them pay the same copays and other cost sharing that they would have paid for in-network care if they end up getting treated by an out-of-network provider. We respectfully urge your support of this consumer protection legislation.
Good afternoon. Betsy Imholtz from Consumers Union. I'm Special Projects Director for Consumers Union, which is the Policy and Advocacy Division of Consumer Reports. We've gotten scores of stories from California consumers who've had these problems with surprise medical bills. Michael S. from Sebastopol's one, and I've given you a selection of a few others. He was admitted to a hospital for a mitral valve repair operation, and he made sure that his hospital was in network, but he didn't know that the anesthesiologist wasn't. This is all too common a problem. Weeks after the operation, as he was healing from this very stressful heart surgery, he received a bill, a huge bill from an anesthesiologist who at an out-of-network price. Only then did he learn that the anesthesiologist didn't have a contract with his insurer. He had another rude awakening, that he had two out-of-pocket maximums, two separate ones, one for in-network care and another for out-of-network care. So rather than facing a $5,000 limit, which he thought he had, he ended up with a $12,000 limit, combining the two with all the out-of-network charges mixed in there, so more than twice what he thought his liability would be. And he's not alone. It's unfortunately a widespread problem. Consumer Reports has just done a national survey of these network problems, and with a California oversample, and just a couple of key points from that survey, which will be out next week. For Californians who underwent hospitalization or surgery, 1 in 4 were charged out-of-network rates by doctors that they thought were in-network. Secondly, most Californians assume, understandably, that if you go to an in-network facility, you're going to get an in-network doctor. And third, fully 85% of Californians believe hospitals should notify patients when they're going to be served by a technician or a doctor who's out-of-network. 533 would address these problems and take the consumer out of the middle. We thank the chairman for his leadership on it and urge your support for the bill. Thank you.
Elizabeth Landsberg with the Western Center on Law and Poverty in strong support.
Further witnesses in support.
Mr. Chair, member Sarah Flocks, California Labor Federation, in strong support.
Mr. Chair and members, Dolores Duran Flores with the California School Employees Association, also in support.
Julianne Broyles here on behalf of the California Association of Health Underwriters. We appreciate the amendments to the bill and ask for an aye vote.
Maureen Higgins, representing America's Health Insurance Plans and Anthem Blue Cross, in support.
Stephanie Watkins on behalf of the Association of California Life and Health Insurance Companies. We have a supportive amended, but look forward to working with the chair as the bill moves forward. Thank you.
Chair Member Luis Sanchez with Blue Shield of California, also in a supportive amendment position, but we'd like to thank the chairman for bringing this bill and looking forward to working with him throughout the process.
Nick Luizos with the California Association of Health Plans. Latest version of the bill is an improvement of the first one. We also have a supportive amended position and want to continue working with the author to further refine the bill and protect health plan enrollees. Thank you.
Any other witnesses in support? Seeing none. Witnesses in opposition? You may proceed.
Thank you. Good afternoon. My name is Tom Sugarman. I'm an emergency physician representing the California chapter of the American College of Emergency Physicians, and we are in opposition to this bill. While we agree that the patient should not be in the middle, this bill does not address the problem adequately and has a number of unintended consequences. The primary effect of this bill will be to encourage health plans to no longer contract, and that will be because they will essentially be able to pay whatever they would like to pay. There's nothing in the bill right now that will control or regulate how much the insurance company will have to pay. And although we've heard that there are some proposals to put an independent dispute resolution program in place, that alone will not be sufficient to solve the problem. The effect of this will be that on-call specialists will be much less available. We already have a great problem getting on-call specialists to respond to the emergency department to provide things like orthopedic surgery, neurosurgery, emergency procedures for severe gastrointestinal bleeding. And so without that ability, we will not be able to take care of those patients. And already, for example, I had a patient just last week who came in with back pain, ended up having an epidural abscess, which means she had a very severe infection around her neck in her spinal cord, and without treatment, she will become paralyzed. And the longer that treatment is delayed, the more likely it is and the more disability she will have. It took me about 3 hours calling 2 hospitals and talking to doctors 5 or 6 times to get her transferred for adequate neurosurgical care, and that's due to the lack of availability of on-call neurosurgery. There are multiple other examples of that. So we respectfully ask that you vote no on this bill unless it can be fixed so that we can address a fair payment mechanism to ensure there continues to be access to care. There's no point in having the patient out of the middle if out of the middle means they just can't get the care that they need. Thank you.
Chair and members, I'd like to thank the chairman for bringing the bill and having the continued discussions. This bill comes about when an HMO or a PPO patient receives care at a participating facility and gets service from a non-contracted physician. It's a responsibility of health plans to offer adequate networks to their enrollees to ensure that when they do go to a participating facility, they are limited to their in-network cost share. If they do receive care from a non-contracted provider, we believe it's the responsibility of the health plan, not the patient, to arrange for that care and pay fairly. We are greatly concerned the current version of the bill, it does take the patient out of the middle, but for our non-contracted providers, basically they're at the whim of what the health plan will decide to pay them. And the only recourse is to sue them. And that's typically what happens a lot of the time. Providers will collect cases, bundle payments, and then every year or two bring a case against a certain provider where there's no underlying contract. But we've had very good discussions with the author and the sponsor. We'd like to thank them for that as we proceed towards finding a solution that all parties can agree to. Thank you.
Further witnesses in opposition.
Mr. Chairman and members, Tim Shannon, representing the California Orthopedic Association, agree with the remarks that have been made before. What we're hearing from our members is it's a surprise to them too often when they find out they're not in the network. Often they'll deliver care, they'll be authorized to deliver care, and they find out later that they're not part of the network, that they've been dropped. It really is only the health plan that knows which providers are in the network. Often the providers do not know themselves. And Senator Hernandez has a bill on the other side which is going to hopefully address some of this problem by enhancing provider directories so that patients can find out if providers are in the network. We'd like to work with the author, continue to work with him to discuss some of the ideas that he has, but we agree with the remarks that have been made before that at the end of the day, the unfortunate unintended impact of this bill is there will be no need for plans to even have contracts or networks. Thank you.
Mr. Chair and members, Bob Ackerman on behalf of two hospital-based specialties, radiology, pathology, share the comments of the previous witnesses in terms of the concerns with the current version of the bill. Respect the chairman's desire to solve the underlying issue here, which is a fair payment mechanism. So if that can be included in the bill, pathologists, radiologists prefer to contract, prefer not to bill patients, and deal directly with plans. So if we can get to that point, I think we have, a good concept.
Further witnesses in opposition.
Mr. Chair, members, Bryce Docherty on behalf of the California Society of Anesthesiologists. We're in an opposed unless amended position. We're encouraged to hear the chair is interested in having a dialogue on a methodology around an independent dispute resolution process. No patient should be getting a surprise bill, but there does need to be some sort of remedy to maintain those services, particularly anesthesia services. Thank you.
Thank you. Any other witnesses in opposition? Seeing none, questions or comments from the committee? We have a motion from Mr. Thurman. Second from Mr. Oh, did we already have one? We already had one. We have multiple motions, so that's we're being thorough here, Mr. Chair. Mr. Chavez.
Senator Bonta, can you address a little bit how you're working with the doctors? Because I hear what they're saying, and I want to make sure that we're not putting them in a tough position. When I start hearing people say sue, lawsuits, that gets my attention. So what are you doing?
Thank you, Assemblymember Chavez. The way we proceeded with the bill was we started with the core component that everybody agrees on. Pull the patient out of the dispute. When they've done everything right, they've gone to an in-network facility and they get stuck with a surprise bill that's very high from an out-of-network provider. Everyone agrees on that. That leaves a very open discussion about how the provider gets fair payment. Right now, there's not agreement by the plans and the providers, but a number of proposals have been put forth. Right now, the independent dispute resolution process is one that might have some legs, and we're going to investigate it and work with both sides and see if we can accommodate. So we understand that there's an open question. Our bill is silent on that issue right now. We feel that it would be a stronger bill if that silence was filled with content and substance, with input from all the stakeholders. So I think the concerns that were raised by the providers here today are concerns that I have about the bill also. And so I'm committed to working with them and the plans to get to a resolution that we can all live with.
So it's your intent that bringing the independent, what's the independent?
Dispute resolution process.
Resolution process, you plan on doing that?
I plan on exploring if it's a way to work. I'd want the opposition to come off or at least be softened. So I think it can make progress. I don't think anyone at this table should prejudge that yet, since we haven't looked at the details. So let's be open-minded. Let's consider it as we go forward. I think that's the best possibility now. But there could also be some improved communication between the plans who know which providers are in-network or out-of-network. So some of the ideas that they've come forward with have great potential.
And I'll be supporting your bill today to go forward to do that, but I will reserve my right on the floor just to be totally front, because you and I have talked about this a little bit, so I want to be true to my word to you.
I appreciate it. Thank you, Assemblymember Chavez.
Mr. Patterson.
So there's an open hole, I guess, in the bill with dispute resolution, and also, as I understand it, an open hole with respect to who's going to get paid, how they're going to get paid. Are you intending to close that hole as well?
They're one and the same. So the independent dispute resolution process will determine who pays what in addition to the in-network cost share that the patient is paying. So the bill as written limits and caps the patient's cost at the in-network price, even if an unexpected out-of-network provider participates in whatever procedure or care that they get. And then we'll have a dispute resolution process as one possibility to determine how much, if any, the plan will pay in addition to that, to make sure that there's reasonable and customary value is being provided in terms of the payment, and the IDRP process is not something that we've made up. It exists now, and there's a 6-pronged test called the Gould criteria, and there's a external reviewer who provides a specialty third-party independent look to make sure that the provider gets reasonable and customary reimbursement for their work. So that's what we're looking at. We think that could be massaged and worked on and built upon to create a strong process that allows these providers to get fair reimbursement.
To those who expressed the reservation. Does that, as outlined, satisfy your opposition?
On behalf of the California Medical Association, the concept of a IRDP process would or could remove our opposition. Obviously, those processes or those types of dispute resolutions can take many different forms. You can basically create any type of dispute resolution process that you'd want in this case. So on that fact, the devil really is in the details. But conceptually, an IRDP process that we would sign off on would remove our opposition from the bill.
Others in opposition?
Yes.
Would that remove it?
There's two parts really to how to ensure a fair payment. One is to have some sort of dispute resolution process and a way to measure what's a fair payment. But the other problem that we see here, and this is what we've seen across the country with other IDRPs and even within the California IDRP, why they do not work, is that you need to have some sort of initial or interim payment standard, because the insurance companies are very large companies and they have very large cash flow. Most doctors are fairly small businesses. And so if the insurance company just simply decides to lowball the numbers, which is what they've done historically across the country, the doctors cannot manage that cash flow, the loss of the cash flow, and wait for the IDRP to solve its problems. And it's just basically gambling on for the insurance companies. They can play that game and let the money go for a while. So in order to have an effective IDRP, there would have to be some sort of fair payment standard where initially the insurance company would have to pay something that would be agreed upon that could be fair, and then you could take whether that payment should be higher or lower if the insurance company feels that the doctor overcharged, or if the doctor feels that the insurance company underpaid based upon the interim payment standard, then that would go to the independent dispute resolution program. But without that, I don't think that an independent dispute resolution process will ever be fair. And I just want to point out one other thing, that unlike the other specialists which the sponsors had disclosed, emergency physicians have no choice. We're going to see all patients when they come in to see us no matter what. So we don't have the opportunity to talk to our patients beforehand and tell them whether or not we're in network, whether or not what their bills are going to be. And largely the reason that we're not in network is because we can't get fair contracting rates. This bill will further encourage, the way it is right now, will further encourage insurance companies to lowball contracting rates, and more people will come out of network, creating more of a problem and less access to care.
Thank you.
I can't speak to the IDRP so much. I do listen very carefully when the chairman of the health committee says that he is open and willing to discuss other options, and we plan to work with him, and I think we can move towards removing our opposition. I would like to focus more on the responsibility of the health plans to have up-to-date and accurate directories so that a patient can look and see if the anesthesiologist is in network or not. And that's really the problem, because the patient is put in the wrong position when they don't know that.
Appreciate the opportunity to ask the questions, and Mr. Bonta, I commend you on attempting to be Solomon.
Thank you, I think.
Mr. Wood.
Mr. Wood.
Yes, and thank you, Mr. Bonta, for bringing this forward. I appreciate that. I'm encouraged by the conversations around the independent dispute resolution process. I appreciate that. I know that you're going to continue to work on these issues. I will be supporting your bill. I was a little concerned when I heard that, and this would be, trust me, as a former provider, a real shock to find out that I thought I was a provider in a network, only to find out that I wasn't at some point. That is pretty disturbing, and I could see that we might have some challenges around that. So I hope that I hope that that's something to take into consideration in the future. Thank you.
Thank you, Dr. Wood. And I've heard you make that very compelling point a number of times in this committee and our joint hearings, so that's something we'll look at closely.
Any other questions or comments from the committee? Mr. Bonta, I really appreciate your commitment to work with the opposition. I had some of the same concerns prior to the meeting, but certainly with the dialogue that I've heard here, the commitment I've heard here, I feel comfortable supporting this as you move this forward. So I certainly will be in support as well. With that, we have a motion and a second. I'd ask the clerk to please call the roll. It's due pass as amended to approach.
Bonta?
I think it's an aye.
Bonta, aye. Mainshine?
Aye.
Mainshine, aye. Bonilla? Burke? Burke, aye. Chavez? Chavez, aye. Chu? Chu, aye. Gomez? Gomez, aye. Gonzalez? Gonzalez, aye. Hernandez? Hernandez, aye. Lackey? Lackey, aye. Nazarian? Nazarian, aye. Patterson? Ridley Thomas? Rodriguez? Rodriguez, aye. Santiago? Santiago, aye. Steinnorth? Steinnorth, aye. Thurmond? Thurmond, aye. Waldron? Waldron, aye. Wood? Wood, aye.
Your motion passes 15-0.
Thank you, colleagues.
Next is item 25, AB 13. Hold on just 1 minute, Mr. Chair.
16-0.
It was, for those keeping track at home, it was 16-0. So, with that...
I noticed that, but I wasn't going to say anything.
You noticed that, but you forgot to vote, so we got to wait it out.
You're right, exactly.
We got to wait
So
it
it all balanced out.
Next is item 25, AB 1396. Mr. Chair.